Hello, my name is Adam Singer and I'm a diagnostic radiologist from Atlanta, Georgia, and today I'll be discussing shoulder arthroplasties. This will be part one of a series where I'll begin talking about the background about shoulder arthroplasties and go through some of the radiology information. And part two will be a discussion with my orthopedic colleagues, Dr. Charles Daly, Dr. Michael Gottschalk, and Dr. Eric Wagner. I want to thank them for providing some of the images for the part one presentation. Just a quick reminder, this video and all the videos on my channel are for educational purposes only and should not be used to make medical decisions. So basic video structure, we're going to begin with the pathophysiology and the kinetics of the shoulder and discuss some of the background and measurements that are commonly discussed. So just the pathophysiology, we have dynamic stabilizers and static stabilizers. So the dynamic stabilizers are primarily the rotator cuff. These are tendons that are attached to muscles, and their job is going to be, in addition to creating motion at the shoulder joint, they will compress the humeral head centrally in the glenoid, and basically in all motions keep the humeral head centered with respect to the glenoid. The static stabilizers are things that aren't attached to muscles and don't move, but provide structural integrity to the joint. And this is really important because we want the humerus to have a lot of motion at the shoulder joint so that we can move our arm around and do things. And in order to do that, we can't have the joint constrained like we do with, say, the hip, where you have a lot more bony coverage. And so you basically have this giant golf ball, which is the humeral head, sitting on a small tee. And though that allows for a lot of motion, it causes inherent instability. And so these dynamic and static stabilizers are very important to allow us to have this motion but keep us stable. And so I'm just drawing some lines here showing some of the primary vectors involved in what we're going to talk about. And so the rotator cuff is going to cause compression and centralization of the humeral head with respect to the glenoid. You've got the anterior cuff and posterior cuff working together to do that. And then the deltoid, which is not part of the cuff, but the muscle just outside, is going to be primarily the big abductor and will try to pull the humerus cranially. So the deltoid abducts the shoulder, it elevates the humeral head, and given that it has anterior, middle, and posterior bodies, will provide some degree of shoulder flexion and extension. The supraspinatus really initiates abduction minimally of the humeral head, but primarily one of its functions is to hold the humeral head down. The infraspinatus and teres minor are going to pull down the humeral head and externally rotate, and they provide some degree of abduction, while the subscapularis will keep the humeral head down also, keep it centered as well, and also internally rotate the humeral head. So what is a shoulder arthroplasty, or what is an arthroplasty in general? An arthroplasty is a reconstruction or replacement of a joint. So there are a couple of different types of arthroplasties that you're going to run into with regard to the shoulder. The first is a resurfacing arthroplasty, and so in this case you replace the humeral side only, and really you're not using up much of the bone stock, so it's just going to be the articular surface of the humerus. The glenoid is left alone, you don't really have a stem. This would probably be more in line with a hemiarthroplasty compared to a total arthroplasty, but a lot of surgeons make a distinction between resurfacing arthroplasties and hemiarthroplasties. But primarily they're serving similar functions, that is preservation of bone stock in young patients who have unilateral problems at the joint. And so in this case it's going to be the humerus side that's going to be problematic, the glenoid side is going to be okay, and indications for this would be AVN, large Hill-Sachs lesions, humeral-sided fractures in young patients. So this is just an example. You can see that they had a ballistics injury to their shoulder, and they have just the humeral head replaced. The glenoid is there. You can see that there's some narrowing of the joint, which is going to be important with respect to resurfacing and hemiarthroplasties. You can see that they're actually starting to develop osteoarthrosis on the glenoid side of the joint as well. Probably the humeral component, ideally you want to have it mimicking the normal anatomy of the humerus. This may be just slightly large. So here's a patient who has avascular necrosis of the humeral head. You see the serpentine area of sclerosis here. No secondary osteoarthrosis. The joint space is preserved. And so another resurfacing design here. And you can see in this chest CT reconstruction that the joint is preserved. The next type is a hemiarthroplasty. So you see this larger component, again, just the humeral side with the stem here. Here's another one here, probably a little bit large again. So when you overstuff joints and you have too large of humeral components, that can potentially be problematic and lead to failure. Again, younger patients with similar indications with the glenoid being okay. Here's another hemiarthroplasty, another potential indication. This patient had multiple myeloma with a neoplasm near the shoulder, and they elected to do a hemiarthroplasty. You can see some healing over time of that lesion. So what are the complications? The most common is going to be glenoid osteoarthrosis. So you've got metal directly on cartilage, and over time it's just going to wear it down. And so that's what you're seeing here. You see the narrowing of the joint space. You've got subchondral sclerosis and cystic change, and to some degree erosion of the glenoid side here. Aseptic loosening, heterotopic ossification, hematoma, periprosthetic fracture, infection, subscapularis or supraspinatus tendon tears. These are potential complications for any of these implants. The subscapularis is worth mentioning specifically. So when the surgeon goes in and replaces the joint, they often take an approach initially going through the delta pectoral groove, but ultimately having to enter the joint, often violating the subscapularis. And there are several different techniques to try to fix the subscapularis, and sometimes they do it and sometimes they don't. Sometimes they do it and it fails. But that's important because you can end up with instability when the subscapularis isn't working, potentially having the humerus dislocating or subluxing anteriorly. So when you see post-operative radiographs, if the humeral component is too far anterior, you want to really carefully look at that subscapularis and see if it looks like it's atrophied or if you can see the tendon pulled back on an MR. So next is an anatomic total shoulder arthroplasty. This is going to be replacing of both sides. You must have an intact rotator cuff to have this type of implant. And it's an anatomic reconstruction, meaning that the ball remains the humeral side and the socket remains the glenoid side. A lack of an intact rotator cuff will result in superior humeral head migration, which is going to increase risk of glenoid component loosening by creating a rocking horse effect on the glenoid component. So it's going to sort of rock it and ultimately loosen it. So this here is a case of AVN again, but you can see they're already developing osteoarthrosis. You see this osteophyte here. On other views, there was some narrowing of the joint space, so they went in and replaced it. And unlike the hemiarthroplasty and the resurfacing, if you look carefully, you can see that there's this marker here telling you that there's a polyethylene glenoid component. You can sort of make out these little loosened screw tracks here. And so the anatomic total shoulder arthroplasty glenoid component in modern time often is made of primarily polyethylene, that they usually don't use metal, and the only metal you may see is just this marker here. The implant may have pegs or a kind of triangular keel, and they're skewing a little bit more towards pegs from keels because studies have shown that the keels may fail more often than pegs. But you want to carefully scrutinize the joint and make sure that you don't have a total if you think it's a hemi. The indications, the big one is going to be primary osteoarthrosis, but you can see there's a series of other indications here, and there is some overlap and surgeon preference and things related to patient factors that may push the surgeon to either go towards anatomic or reverse. So there is overlap, and it's worth to note that. So here's a case of primary osteoarthrosis. You can see that there's joint space narrowing. You've got subchondral sclerosis and cystic change, marginal osteophytes. The humeral head is slightly posteriorly subluxed. And on the MRI, you can see there's probably some degree of partial thickness tearing of the cuff, but for the most part, the cuff is intact. The muscle is not atrophied. Joint space narrowing, these osteophytes coming off the humeral head, sometimes likened to a goat's beard. And you've got the end plates of the subchondral bone plates, I should say, of both sides of the joint are irregular. There's subchondral cysts, edema, sclerosis. So this is typical of primary osteoarthrosis. These are examples of anatomic total shoulder arthroplasties. This one has cement. You can see this radiodense area here with this loosened area underneath it. Again, the marker is showing you that there's a polyethylene component with these loosened areas being the tracks for the pegs. Sometimes they're cemented, sometimes they're not. This one looks like it's probably starting to loosen a little bit. The humeral components here. You want to restore the normal anatomy. So the humeral component should be the same size as what the native humeral head looked like. If it's too big or too small, it may predispose to failure. Here are other examples of total shoulder arthroplasties, anatomic. You've got a glenoid component that's partially metal backed here, so you don't see these as frequently, at least at our institution. Most of them are polyethylene completely. Here you can see that this implant has failed. There's lucency at the glenoid side. The humeral head has migrated superiorly and is remodeling the undersurface of the acromion. This is a CT arthrogram. And if you look here, we injected iodinated contrast into the joint. You can see contrast all the way around here. And then you see this high-density material going underneath the polyethylene liner. So here is the liner. You can see the threads of this peg here. They're usually low density, and you can see the liner here, and there's this high-density material. So the question is this loose, and this is contrast getting underneath the implant? So we typically do a pre-injection CT as well, just so we can compare the two. And here you can see before we do the injection, the high density material underneath it. So this is actually cement and not contrast getting underneath it. So complications, the most common one is going to be aseptic loosening, typically of the glenoid component first. Later you may have humeral component loosening. Again, more common with the keeled versus the pegged configuration. And then some of the more common complications between the different types of implants: HO, hematoma, fracture, subscapularis insufficiency, ultimate tear of the supraspinatus tendon, which can lead to failure of the glenoid component by that rocking horse mechanism. And then metallosis can occur from any of them, especially if you've got metal-backed hardware or metal components that fracture. Finally, we have the reverse total shoulder arthroplasty. Again, we're replacing both sides. The reverse is commonly used when the rotator cuff is out. The anatomy is reversed. So now the ball is the glenoid and the socket is the humerus. In order for this to work, you must have an intact deltoid, because the deltoid is what's going to allow this shoulder to regain function. So you can think of this as a semi-constrained implant where it's acting as a fulcrum, replacing the torn rotator cuff and allowing the deltoid to function. So that's one of the reasons why this is such a successful implant. Historically, this was used for rotator cuff arthropathy, so when the rotator cuff was out. You can see that the indications have continued to increase over time. So failed arthroplasties with revisions will often go to a reverse. OA with excessive retroversion, proximal humerus fractures, inflammatory arthritis, recurrent instability with bone deficiency. So really, again, a lot of surgeon preference and patient factors may go into selection of what type of arthroplasty. In general, the reverse shoulder arthroplasty is made of 4 components, and we'll look at each of these individually. So the first is the glenoid side. You're going to have a ball, which is the glenosphere, and then a base plate, sometimes called the metaglean base plate. And this will have a central screw in most of the models, or at least the models that we see, with anterior, posterior, superior, and inferior screws. On the templating software that our surgeons use, you'll see the same thing: the central screw, the anterior, posterior, superior, and inferior screws. So this is templating software that they use. They take the CT scan and they put it in the software. The software will help them sort of plan their surgery. So in this case, showing the seating of the glenoid component, you can see this is a small glenoid with only 44% seating, so the surgeon knows that he's going to have to do some sort of bone grafting or augmentation of the posterior superior glenoid because it's too small to accommodate the hardware. And it's going to tell him, the degree of inclination, lateralization, and the version as well. So this is the humeral side. You've got the humeral stem and the loosened polyethylene liner. Typically, you're going to see that the humeral component is inferior and medial to the native position of the de novo humeral head. It's going to be right underneath the glenosphere, and often you'll see the glenosphere is pointed downward. Again, from the templating software, you can just see some of the calculations that are going into where they're going to put the humeral implant. So complications, excessive medialization can result in scapular notching and also impingement on the glenoid during internal rotation by the polyethylene liner. Excessive stress on the deltoid or by the deltoid can lead to acromial and scapular spine stress fractures. The common complications, dislocation usually anterior, again relating to that insufficient subscapularis. Aseptic loosening, again, frequently the glenoid is going to be first. Acromial and scapular spine stress fractures, as I mentioned. Nerve injury, so there are reports of nerve injury related to the screws for the glenosphere and base plate. So the superior screw potentially can go into the suprascapular notch. Remember, that's a smaller space than the spinal glenoid notch, and then it's bound cranially by a ligament, and there's vessels inside of it, so less room to accommodate screws. The posterior screw has been reported to get into the spinal glenoid notch and potentially cause problems. The axillary nerve you don't typically see as being a problematic area because that's usually protected at surgery. They're very careful about that nerve because that's the nerve that innervates the deltoid, which is essential for a functional reverse total shoulder arthroplasty. Component disassembly, hematoma, and periprosthetic fracture. So just a short primer on imaging of the shoulder arthroplasty. I could do an entire talk on just the imaging of arthroplasties and in the presence of metal, and I'm just going to touch on some of the high points. So with MR, we know we have magnetic susceptibility artifact. With CT, beam hardening and photon starvation, and there are known limitations to ultrasound. So just a couple of example cases here. This is actually a stir, which we use frequently with metal because it's typically a little bit better, but you can see good examples here of some of the problems with metal, especially in the setting of a shoulder arthroplasty. So in plane distortion, you get signal loss due to dephasing of spins, and it results in this black sort of fuzzy spot around the metal where you can't really see much. Poor fat suppression, again, frequency selective fat set will be the worst, or gradients would also be problematic more with the signal loss, but you'll have worsening fat sat when you don't use stir, and even though you have a stir here, you can see where there's failure of the fat sat. Geometric distortion, so shifting tissue further from its location to distorting structures. When you couple that with motion artifact, it sometimes becomes very difficult to even figure out that you're looking at a shoulder. And then through plane distortion is another problem as well. So these are some of our techniques that we use to try to combat the artifacts on MR. And you can see in this case pretty well the polyethylene components in the glenoid because there's no metal. Here's the CT. We're still struggling a little bit with the humeral side here, but less than when you compare to these images here. So you can see that there's a significant difference in what we're able to see with some of these proprietary metal suppression techniques. With CT, beam hardening and photon starvation, so in short, beam hardening is preferential attenuation of the lower energy photons, so you get loss of soft tissue contrast and dark streaks near the hardware on reconstructions. Photon starvation, the X-ray beam hits the metal and is attenuated, so the X-ray beams don't reach the detectors as well, and you end up with these fine, bright, and dark streaks. There are different ways to suppress metal. We typically use the MAR, which is, in our case, we're not using dual energy, it's just this MAR algorithm, and it's helpful, but it generates artifacts of its own. So here's the source bone algorithm CT, and you see all these streaks going out from all over the periphery of this implant. You can see the MAR really cleans that up quite a bit. These are the same levels here. You can't really see the interface between the hardware, the base plate, and the native glenoid, whereas you can on the MAR. You see a little bit more of that internal architecture, but one of the problems are the artifacts that the MAR generates, and you can see an example of that here. So I changed the windowing a little bit. You can see the threads from the screw here pretty well. On the MAR, the threads look dark, so this is artifact here. And another example of that, the MAR shows apparent discontinuity of this screw here, so you may think that this is a fractured screw, but on the source bone algorithm image, you can see that the screw is intact. So again, the same level artifact generated here. It accentuates this artifact here that almost looks like gas, but this is not gas. When you scroll through it, it goes right through the metal there. So just keep in mind that it's helpful, but you want to use both of these images side by side and not just rely on the MAR. And I gave just an example image of ultrasound, limited by tissue contrast, penetration, so you end up losing spatial resolution as you have to drop your frequency on your transducer. So deeper structures are harder to characterize, and it's operator dependent. So just a little bit on the kinetics and pathophysiology. So under normal circumstances, the center of rotation of the humeral head is roughly in this region. The moment arm of the deltoid that is important for the efficiency of the muscle here. And the moment arm will be related to the distance from the center of rotation. So shifting the center of rotation closer will shorten the moment arm and decrease efficiency. Further away to some extent will increase the moment arm and increase efficiency. And in this position, the rotator cuff anterior and posterior is taut, so it's going to allow for rotation, internal and external rotation of the humeral head. So this is the normal anatomy. With rotator cuff arthropathy, you get superior migration of the humeral head, in part by removal of the intervening supraspinatus, but also from the pull by the deltoid. And this results in shortening of the deltoid, limiting its ability to contract. And so when you can't really contract above and fire to abduct the shoulder above the horizontal, that term is pseudoparalysis. You still can passively be abducted beyond it, so it's not like there's a block mechanically. It's just that functionally the deltoid is having a tough time getting you above the horizontal. So there are multiple versions of the reverse shoulder arthroplasty. One of the first ones was this medial glenoid medial humerus, the Grammont. So the humerus in these cases is translated inferiorly and medially. This results in elongation and medialization of the deltoid, which is going to increase that moment arm and make it work more efficiently. However, it can also result in excessive force on the acromion when it's translated too inferiorly. That can predispose to stress fractures. And then excessive medialization when you adduct can result in impingement on the scapular pillar here and scapular notching. Medialization of the center of rotation from more over here towards this region will reduce the torque on the glenosphere and in theory will decrease the risk of loosening of the glenoid component. Some of this material is going to be somewhat controversial, so we may have to discuss this with the surgeons in part 2. Medialization will potentially decrease cuff tension. So you can see in this model the subscap being a little bit redundant, so in theory would decrease rotational strength with this model. So just on scapular notching, this is impingement of the humeral cup against the superior scapular pillar or neck when you do shoulder adduction. Servo graded this based on how much of the bone was eroded, grades 1 through 4. So if you had erosion that did not reach that inferior screw, it would be a 1. If it reached the screw but didn't extend above it, it would be a 2. If it passed above that inferior screw, it would be a 3. And if it reached the base plate or the central screw, it was a 4. Grade 3 plus has been associated with loosening of the glenoid component. A lateral glenoid medial humerus reverse, the humerus is translated inferiorly and laterally. This results in lateralization of the center of rotation, so like this, which in theory, according to some people, could decrease the efficiency of the deltoid relative to the medialized center of rotation. This will reduce scapular notching because it brings it further away. It will also tension the rotator cuff, so you'll have more rotational strength. And the lateralized center of rotation, in theory, could potentially generate more torque on the glenoid component and may increase the risk of loosening. Finally, the medial glenoid lateral humerus. The humerus is translated inferiorly and laterally. The center of rotation is medialized, so that reduces torque. You increase the moment arm, so you increase efficiency, and you're going to decrease the risk of impingement because you're still lateralizing the humerus. So when is an arthroplasty done? In the case of the shoulder, it can be performed for a number of reasons: primary osteoarthrosis, rotator cuff arthropathy, sequelae of inflammatory or infectious arthritis after trauma due to the presence of tumors or as a complication of AVM. So primary osteoarthrosis is where It's usually going to be posterior and inferior, and usually without superior humeral head migration. So this is wear and tear and not due to other causes. So you'll typically potentially see with some of this posterior decentering of the humeral head. Humeral head osteophytes are common. These have been likened to the goat's beard when looking at it on the frontal or coronal projection. You may see reactive changes in the subchondral bone. So you can see here there's a sclerosis and cystic change and potentially erosion of the glenoid. And so the terms that you may come across will be paleoglenoids. This is the premorbid glenoid denoted here, and the neoglenoid, which is the eroded morbid glenoid here. And so some people advocate when you're making version angles to combine both of those to make an intermediate glenoid version angle. So this is the same patient, MRI and X-ray. You can see the joint space narrowing. You see that goat's beard, osteophyte, stuff going on down here. But I'm demonstrating that the rotator cuff is intact. You don't have severe atrophy of the muscles. The cuff is intact. But you do have this posterior sort of biconcave appearance, decentering of the humeral head, tearing of the posterior labrum here. So this is primary osteoarthrosis. And Walsh classified primary osteoarthrosis into 3 simple categories. This has been since expanded upon, but I'm just going to do the simplified version here. If the humeral head is not posteriorly decentered, that would be an A. If there's posterior decentering, it would be a B. And if there is retroversion of the glenoid greater than 25 degrees, it would be a C. If there is minimal to no erosion, it would be a 1 morphology. And if there is significant erosion, it would be a 2. So glenoid version, it's which way the glenoid is angulated. And studies have shown that measurements made with 3D images are more accurate than 2D images. I'm going to show a 2D measurement here for a lot of this, but the 3D measurements are generated on some of that templating software that your surgeons may use. So the measurements are going to be made at or just below the coracoid tip. And you want to keep in mind that uncorrected excess retroversions are greater than 10 degrees may predispose to arthroplasty failure, especially if it's not corrected. So to do this, you're going to draw a Friedman line first. So this is going to be the line from the medial tip of the scapula to the center of the glenoid, again, at or just below the level of the coracoid process. You're going to draw line 2, which is a perpendicular, and then line 3 is going to be across the face of the glenoid, and you're going to exclude osteophytes. And if it's opening this way, it's anteverted, retroverted this way, and the angle between lines 3 and 2 will be the version. Normal can be anteverted up to 7. You can have some degree of retroversion as well. Typically greater than 10 degrees is going to be pathologic, and then greater than 25 degrees is going to be a Walsh C. So this is just some of the templating software. So the source CT here, and then it's put into this software, and the software spits out measurements here based on the 3D modeling. Glenoid inclination, so again, you draw the Friedman line, you draw the perpendicular, and then you make the measurement across the face of the glenoid, excluding osteophytes. You can either have superior or inferior inclination. And here, again, the inclination measurement being provided by the software. Method 2, which some advocate for as being more accurate, would be the beta angle measurement. So you're going to, instead of using the Friedman line, you're going to use a line parallel to the supraspinatus fossa, the perpendicular, and then the line here. And some people think the reason it would be more accurate is because it better accounts for the scapular body rotation than method 1 that I just mentioned. The range of normal is not really clear, but superior inclination after glenoid component placement may predispose to loosening. The glenoid vault is just a term for the bone stock here, so you're making a measurement of the degree of remaining cancellous bone deep to the subchondral bone plate, and you want to have enough of a glenoid vault to accommodate the screws and the base plate. So if you lose your bone stock, you're going to potentially have to augment or bone graft to allow for placement of the hardware. So the measurement is made basically center from the subchondral bone plate to the apex here of the triangle. But you not only do you want to measure that, you also want to look for symmetry, so anterior and posterior, because you can have preferential wear in either location. Commonly, you're going to see it posteriorly. And so if you have excessive posterior wear, there may, again, be a need for augmentation or bone graft. For humeral head posterior subluxation, again, the Friedman line is drawn. Then you go and you draw perpendicular across the humeral head so it passes from the widest part of the head from anterior to posterior. And then subluxation is calculated as the percentage of the humeral head that's posterior to the Friedman line. In this case, this is about 72% posteriorly subluxed. Keep in mind that uncorrected posterior subluxation will increase the risk of glenoid wear and loosening. So secondary osteoarthrosis, there are a number of causes. Rotator cuff arthropathy, so I kind of touched on this already, but the dynamic stabilizers are damaged. The rotator cuff is important to hold the humeral head against the glenoid, and with large tears, the stabilization is impaired, leading to abnormal motion. Large super and infra tears lead to unopposed deltoid function, superior humeral head migration, loss of the mechanical block of the supraspinatus between the acromion and the humeral head, and this leads to potential femoralization of the humeral head, where the interface between the humeral head and the tuberosities is worn down due to osteoarthritis, and it is likened to the top of the femur. And then acetabularization of the acromion, so you sort of erode the undersurface of the acromion, and it looks like an acetabulum. Often you'll also see damage because of the high-riding humeral head to the superior glenoid and to the biceps labral anchor complex. You may see slab tears, partial tears or tendinosis, or even complete ruptures of the long head of the biceps tendon. And we already touched on pseudoparalysis, but inability to actively abduct the shoulder past the horizontal with preserved passive abduction. So this is an example of rotator cuff arthropathy on MR. Massive rotator cuff tear, 2 or more tendons completely torn, retracted. The humeral head is superiorly subluxed or migrated, and you can see that there's sort of this concave appearance here. And then on the sagittal T1, you see that there's atrophy of supraspinatus and infraspinatus. Biceps tendon has ruptured. Corresponding CT, narrowing of the acromial-humeral interval, which we'll discuss in a moment. You can see that this is no longer centered with respect to the glenoid. And on the soft tissue algorithm, you can actually see atrophy of the muscles of the rotator cuff, like we just saw in the T1 MR image. So rotator cuff arthropathy was graded by Hamada and Seebauer in separate systems. The Seebauer one a little more complicated, but Hamada is probably easier just to make measurements with. Stage 1, the acromial humeral interval is greater than or equal to 6 millimeters. Stage 2, equal to or less than 5 millimeters. Stage 3, equal to or less than 5 millimeters with acetabularization. So you can see acetabularization here, remodeling of the undersurface of the acromion. Sometimes even with the clavicle you can see it. 4 is going to be with associated glenohumeral joint space narrowing, subdivided into A and B if it's less than 7 without acetabularization A, 5 or less with acetabularization B, and if you have AVN with less than 5 or 5, you're going to be stage 5. So normal acromial humeral interval is going to be 8 to 12 millimeters. Greater than 12 may suggest the presence of an effusion, a big bursitis, inferior subluxation, loss of muscular tone, so contralateral motor stroke. And then at about a level of a 6, you're going to start thinking about a rotator cuff tear. Favard came up with a glenoid wear classification system for rotator cuff arthropathy. So central wear, this is more of like a sagittal view of the glenoid, is going to be an E1. Superior wear isolated is an E2. If the superior wear extends inferiorly, it's going to be an E3. If it's isolated inferior, it's going to be a 4. So this is secondary osteoarthrosis due to AVN. You can see that there's been collapse of the humeral head, secondary osteoarthrosis. You can see that it's really worn down the glenoid here posteriorly, the paleoglenoid up here, and you don't see the atrophy, at least of supraspinatus, that we saw with rotator cuff arthropathy, and the MR showing that although there's probably a partial tear under surface here, we don't see the huge cuff tear that we saw on the rotator cuff arthropathy case. Post-trauma, this is someone who had a ladder J a long time ago, and now they have secondary osteoarthrosis. This one, a anatomic total shoulder that has failed, the same CT images here. And this is a CT arthrogram of somebody who had prior humeral fracture, and you can see cartilage, and then there's a portion of the humeral head that's not there. And then the glenoid side, you've got normal cartilage here, and then it's wearing down centrally and anteriorly. So when we look at the muscles of the rotator cuff, you want to try to grade the degree of atrophy. Initially, this was made off of CT, but it's been extrapolated to MR. 50% is the cutoff, so this is normal here. T1 sagittal, you want to make sure you go medial enough to see the muscles. Some fatty streaks would be a grade 1. Fat infiltration less than 50% would be a grade 2. At 50% would be grade 3, and greater than 50% would be a 4. Grades 3 and 4 are associated with worse functional outcomes with rotator cuff repairs, and in infraspinatus muscle may correspond to scapular notching. So now we're going to look at some radiologic findings and case review. So you can pause this at any point just to sort of ask yourself these questions, think, and come up with the answer, but I'm going to go through these just so that we can keep moving. So what kind of arthroplasty is this? This is a reverse total shoulder arthroplasty. This is the first post-op images 2 months out, and you can see that there is a periprosthetic fracture right here. The CT scan showing the same thing. Case 2, the same patient came in now complaining 4 months later of pain on the top of the shoulder slowly increasing. So you want to start thinking based on what we know happens of a potential acromial or scapular spine stress fracture. We don't really see it on these x-rays, but the clinical suspicion should be high enough to prompt cross-sectional imaging. So you can see the CT scan here, the fracture right there. So we've got a stress fracture there, the acromion. And subsequently, you can see the beginning of callus, and the fracture line is more conspicuous. All right, case 3, what type? So this is also a reverse, and this was routine follow-up imaging. The patient's asymptomatic, and one of your colleagues calls you over because they noticed a big area of lucency between the native glenoid and the base plate here, and so they were asking, could this be a failed arthroplasty? And if you look carefully, it looks like there may be some density there, and the glenoid looks a little bit worn down there. So here is the CT scan, and if you look, you can see that there's this piece of bone graft underneath here. So this is a different windowing of it, but this is bone graft that's been placed back here. This is not loosening. And the reason for this is this patient had significant wear of the posterior and central glenoid with really minimal remaining paleoglenoid, and in general just a very small glenoid, so very minimal bone stock. They really couldn't accommodate the hardware, and so they required bone grafting to put the hardware in. If they do not augment, they may have excess medialization, resulting in weakening of the cuff, deltoid, acromial fracture, loosening, etc. So they need to also augment for that purpose. Case 4, slowly worsening pain after prior joint replacement outside hospital 17 years ago. What type of arthroplasty? So this is an anatomic total shoulder arthroplasty. You can see it's a combined metal and polyethylene, and there's a piece of metal down here, and then there's this high density material stuff near the greater tuberosity and filling up the joint here. CT scan shows this metallic structure here anteriorly within the joint, and all this metal debris inside of the joint here and eroding the greater tuberosity there. So this was metallosis after a fractured glenoid component. There have been reports of metallosis occurring, especially in the setting of a partial metallic or metallic-backed glenoid anatomic total shoulder. Interestingly enough, you can see this high-density material within the lymph nodes in this patient along the chest wall and axilla, so this is being taken up by the lymphatics. And they went in and converted this to a reverse total shoulder arthroplasty and debrided a whole bunch. You can see they actually had to debride out of the greater tuberosity as it was eroding in there. Couldn't get all of it out, but they got a lot of it out. So this is a companion case. It doesn't only happen with the anatomic total shoulders. You can see there's significant loosening around the central screw and really around all the screws. If you scrolled through it, you would see that there's a lot of loosening. I gave this sagittal view here so you can see the degree of erosion, so very significant erosion. And so this really is nonspecific. It could be aseptic loosening, it could be infection. The one thing that makes you think maybe this is metallosis is you start seeing this high density material around the joint. You see some of it there. That's not artifact. It was hard to see inside the joint itself, but they went in and did a biopsy, and at arthroscopy you can see this black material all over the synovium, the glenoid components over here, and this came back as a foreign body reaction with metallosis seen arthroscopically. Case 5, what type of arthroplasty? So this is anatomic total shoulder. And if you notice, not only is there superior migration, but there's something else going on. So you've got this extensive erosion around the humeral component with subsidence, a stress riser. This is just waiting to pop out. And the glenoid side is also significantly eroded. And then when you look at the stem that I gave, so progressive shoulder pain after a joint replacement 7 years ago, new recent development of swelling and drainage from a scar, so you're thinking infection. And at surgery, this was culture, there was pus, and it was infected total shoulder. It was alpha hemolytic strep. And then subsequently, they had a couple of other surgeries, and you can see this high-density material in the shoulder joint. It's not quite metal, it's not polyethylene, so what is this? These are antibiotic spacers, so they are laced with antibiotics with the idea of trying to help clear that infection and then ultimately put a permanent arthroplasty in. So when you see these things, you just want to recognize them as antibiotic spacers and know that there's infection going on here. Case 6, patient presents with worsening pain 5 months after joint replacement. What is this? This is a reverse total shoulder, and you can see that there's a fractured central screw. On the CT, again, you see that fractured screw, but you also see in the inferior screw there is erosion around it, and it gets up to the screw and a little bit above it as well. So this is grade 3 scapular notching and glenoid failure with the fracture of the screw. Finally, case 7, putting it all together. What type of arthroplasty? Well, this is a total shoulder. It's a little bit large for probably what the original humeral head looked like. And it is cranially migrated. So the history is kind of interesting, right? The patient started having pain while walking their dog and being pulled hard by the leash. 10 years ago is when they had the surgery, or more than 10 years, actually. But you can see there's significantly remodeling of the undersurface of the clavicle and the acromion. So this didn't just happen while they were walking their dog. So you've got cranial migration of the humeral head, remodeling of the undersurface here. So this tells you that the rotator cuff is probably torn at some point, retracted, and you're developing rotator cuff arthropathy. And we said that that will also predispose to glenoid failure. Well, if you look at the glenoid side, you do see that marker for the glenoid, but that's usually like this, and it's down here. And if you look carefully, there are these loosened sort of linear things with radiodense material surrounding it here and here and here, and the glenoid itself looks eroded. So there's something wrong here, and this is probably a displaced glenoid component. And on CT, you can see that glenoid component here with cement around it, around these little pegs, and here the glenoid component with cement around it, and it has completely pulled out of the glenoid, and you can see the eroded glenoid from where it came, atrophy of the muscles of the rotator cuff, including subscap here, so subscap is not working. So this is basically combination of everything. This is a failed anatomic total shoulder due to rotator cuff arthropathy. The glenoid component failed and popped out. So I'm going to finish up with just no more images, but checklists here. I think checklists are kind of helpful when you're going through this, especially when you're initially learning. So this is the preoperative checklist in terms of CTs for preoperative planning. So the first thing to do is ensure that your planes are oriented with respect to the shoulder before you begin. So if your tech is just hitting the recon button and you're getting it with respect to the chest, it can become problematic, especially if you're trying to do measurements. So if that is the case, you want to reconstruct it yourself with respect to the shoulder joint. Start by looking at an overview. You want to look for evidence of arthritic change. Is it osteoarthritic? Is it inflammatory? Is it infectious? AVN. Look for narrowing, subchondral sclerosis, cystic change in osteophytes. Next, check humeral head alignment. Is it centered? It is potentially Walsh amorphology if it is centered. Keep in mind that the amorphology may be seen in inflammatory arthritis as well, specifically rheumatoid arthritis. Posterior subluxation, Walsh B morphology, you want to grade the degree of posterior subluxation. If there's superior subluxation or migration, measure the acromial-humeral interval. If you can give a Favard wear pattern. And then if it's inferior, suspect effusion, trauma, decreased muscular tone. Glenoid version, is it anteverted or retroverted? Draw your Friedman line, make your measurements, and remember that greater than 25 degrees is Walsh C morphology. Look at the glenoid vault, measured at midpoint, but also look anterior and posterior, and especially if you see posterior wear, you want to note that. If there is wear, erosions, you want to note if there's erosive change, if it looks like it's a Walsh 2 type pattern. Look at glenoid inclination, determine if it's up or down, measure the beta angle. Check the muscles of the rotator cuff for atrophy and grade it with a Gutelier classification. Look at the deltoid, look for atrophy, look for masses and bulk. This is important. If the deltoid is completely out, it's going to make it hard to do a reverse. And then this is probably the most important. So look for the unexpected. As a radiologist, you want to not only look at the joint, but you want to look for other things. So lung pathology. Is there a lung nodule there, a lung cancer? Do you see a breast mass? Do you see lytic or blastic lesions elsewhere? Unexpected fractures. So these are the things that you really want to make sure you don't miss. How about post-operatively? So again, start by making sure that you're oriented with respect to the joint. Then do an overview. So what type of arthroplasty is it? Is it resurfacing, a hemi, an anatomic total, or a reverse total? And if it's a hemi or resurfacing, look at that native glenoid and see if it's osteoarthritic. Look at the humeral component, look for alignment, ensure it's not dislocated. If it's popped out anteriorly, really closely inspect that subscapularis. Ensure the components are not separated or displaced. Look for lucency at the bone hardware and bone cement interface, and pay special attention to the glenoid side. Paraprosthetic humeral fractures, just carefully look at the cortex all the way around the humeral component. Look for acromial and scapular spine fractures, especially in the setting of reverse total shoulder arthroplasty, so any step-off or periosteal reaction. Look for evidence of infection, so in cross-sectional imaging, if you see fluid accumulating or a sinus tract, periostitis that you shouldn't see, sort of globular erosions around the hardware, you want to start thinking about the potential for infection. Look for scapular notching if they have a reverse total shoulder arthroplasty. Look along that medial inferior margin of the scapula and grade it with respect to the inferior screw. Look at the glenosphere and note if you see superior inclination. I probably wouldn't put this in the impression, but at least make note of it in the body. Check the muscles of the rotator cuff for atrophy and grade it. Look at the deltoid. Look for heterotopic ossification. Determine if it's mature, so do you see zonality or is it fluffy? And then grade it. You can probably just extrapolate the Brooker classification from the hip. Check your screw positions and make sure they're not going into the suprascapular notch or spinal glenoid notch. And then again, look for the unexpected. So key points. There are 3 primary shoulder arthroplasties. If you lump the resurfacing and the hemi together, always look for the presence of a glenoid component on your imaging studies. Leverage a combination of radiographs and cross-sectional imaging with metal suppression and possible arthrogram to characterize the post-operative shoulder. Arthroplasties, especially the reverse total shoulder arthroplasty, will alter the normal biomechanics and will result in characteristic complications, so that's why the checklist is important. There are many measurements and grading systems. You want to familiarize with them so you can have an intelligent conversation with your orthopedic colleagues. They may not want you to use the grading system, they may not want you to make the measurements, but you at least want to be aware of them, so if someone asks you about them, you can talk to them. And I would say probably the most important job of the radiologist in the preoperative CT is to look for the things that the surgeon's not looking for. They may be putting this information into a program that's going to sort of spit out these measurements for them. They may be looking at it themselves and be very good at looking at CTs. But the things that potentially would be missed would be the things that are not related to the shoulder. So again, the lung cancers, breast masses, etc. So don't forget to do your normal checklists. All right, and that will conclude part 1. Part 2 will be coming up in the coming days and weeks. I appreciate you taking the time to check out this video. If you have any questions or comments, put them down below. And if you haven't subscribed already, please hit the subscribe button and the notification button so you can find out when new videos come out. I'll see you soon. Thanks.